Hello, and welcome to this month's Simon Says Expert Series. My name is Gene Wurth. By way of background, I am a 75-year-old retiree living in Champaign, Illinois, with a special interest in this subject. About 2 years ago, I was diagnosed with prostate cancer and began the process that brought me here today. Because there is a history of prostate cancer in my family, I have been checking my PSA levels regularly with my primary care physician. When those levels became suspicious, he referred me to a urologist here in Champaign, Dr. John Regan. A biopsy and MRI here indicated cancer, which seemed to be in the early stages and therefore treatable. I was then referred by that doctor, Dr. Clint Bahler, for further diagnosis and subsequent treatment. That process went very well, and I'm very grateful to Dr. Bahler and the wonderful staff at IU Health for a positive outcome. I'm excited to have Dr. Bahler with us today to discuss the value of early detection and treatment of prostate cancer. Dr. Bahler is a urologic cancer specialist who treats prostate and kidney cancers. His research focuses on safer surgeries, better ways to spot cancer during operations, and using advanced imaging to guide more precise, organ-preserving treatments and improved outcomes for patients. Thanks for joining us today, Dr. Bahler.
Hey, Gene, great to be with you, and thanks for coordinating with us. Yeah, my pleasure to be with you and to share field questions, which is a lot of fun to us, but discuss PSA, prostate cancer screening, and trying to avoid cancer, but also trying to avoid side effects of treatment.
I think you've got a program you want to cover with us, general overview of the current status of prostate, or you want to get right into the questions?
Yeah, no, I'd love to chat about that. We are so fortunate at Indiana University. It's kind of hard to believe, but we're arguably the first department of urology in the country. So in 1887, William Niles Wishart Sr. Founded the Department of Urology, and there's just been a lot of legacy and history. And one of the things that's really noteworthy, HIFU, or high intensity focused ultrasound, which is a focal therapy, partial gland treatment for prostate cancer, originated in the basement of our university hospital here in Indianapolis. So HIFU was invented here at IU and brought to the clinical side in the 90s and early 2000s, and now we're do a lot of that focal therapy treatment. And of course, we do a lot of the robotic surgery and work with our radiation oncology colleagues as well for radiation therapy treatment. So it's an exciting time in prostate cancer, partly because it's more image. A lot of our treatment is more image guided. So we have MRI and PSMA PET. Those are relatively new. So 10 years ago, those were not in routine practice. MRI was just starting, and PSMA PET didn't get approval as an imaging agent for prostate cancer until about 4 years ago. So image guided pushes us to think about, how do we limit the treatment? How do we limit toxicities? What's the best way to target the cancer? And so there's a lot of research to be done.
So that technology allows you to be much more precise and much more directed once you've identified where and when a lesion might be in place.
Yeah, we use terms like personalized medicine, but without the imaging to make us confident of where the cancer is, it's hard to trim the treatment or narrow the treatment. With cancer, you tend to treat with margin, right? To make sure you're not leaving a positive margin. So that's right. The personalized medicine now is coming more into focus.
Okay. Should we go right ahead and get into the questions now? That might direct us in the area you want to cover. For those of you who are watching and are listening, I want to remind you that we are tracking your questions as we go along. And I invite you to submit those questions in the comment box below or in the chat if you're joining us on Facebook. We'll begin with the questions that have already been submitted and do our best to answer those in the time we have left. So starting with the questions, I would like to start with one that's kind of generic, but I think is what got me started on the process, and that is, does having an elevated PSA level automatically mean cancer? And what's the latest news about PSA results?
Yeah, what a great question. And I think even for physicians, we don't think about how do you interpret the PSA? And so it really comes down to what can cause the PSA to be elevated. And there's three principal causes. So some guys just have a big prostate, and that's some people are tall, some people have large prostates, and that will mean you're going to have an elevated PSA. So it could be prostate size, and that's not cancer. And some people have, I call it a grumpy prostate. The PSA kind of spikes up and down or bumps up, but then will come back down. And that could be what we call subclinical prostatitis. But typically, and this is why it's so important, if you have your PSA checked and it's elevated, the next step is actually repeating the PSA. It's not, I mean, as a prostate cancer surgeon, I'll never trust a single PSA. It's pretty common to get a spike in the PSA up and that comes back down. So if the PSA is repeated, or if we have imaging to know your prostate size, if we can control for a grumpy prostate and prostate size, then the PSA becomes actually a really good marker for prostate cancer if we can rule out the other two.
Are there any interactions between other prescription medications and the reading of PSA? I know in my case, because of a drug I was on, the number was actually misleading. And it was by deciphering that we figured out that I really needed to proceed with the process we then took.
Wow, that's a really good question. And of course, the answer is yes. There's a medication for hair growth. Finasteride is a generic name. And that's also used to shrink the prostate for men with enlarged prostates. So that's probably the most common one, is the one for hair growth or for BPH or benign prostate symptoms. And it's scary. It will lower the PSA. It'll cut the PSA in half. So if there's cancer, or if you're screening, you really need to know that. And as a simple rule, if you're on that med, you just double the PSA to have your accurate PSA.
So I said earlier that when my numbers got suspicious, it led me down this path, and that's exactly what happened. Because I'd been on finasteride, my number looked good until we doubled it, and then it was no longer such a good number. So, okay. So what are your thoughts on just monitoring once you've identified some presence of cancer? What about just monitoring by checking PSA levels every 6 months? If your Gleason score is low, and you may want to take a minute to explain the complexity of the Gleason scoring system.
Yeah, like most cancers, there's a spectrum in prostate cancer, and not all biopsies that are called cancer, not all, I guess, prostate cancer tumors have the ability to spread. And so there's a big debate in the field whether Gleason 6, or sometimes we call it grade group 1, or sometimes we call that low risk prostate. What do you call it? Do you call it low risk prostate cancer? And based on some of the genetic findings, the pathologists say it should be called cancer. But at that grade, it doesn't really have the ability to spread yet. And some of them are never going to progress. So in the last 10 to 15 years, there's been a big push on the part of doctors and physicians to not overtreat. So if you have a low risk cancer, then most men in that case, the best thing to do is check PSAs a couple times a year, maybe get imaging like MRIs every couple years. You want to make sure you're not missing something, but you don't want to overtreat a tumor that's not going to ever spread or cause harm.
Okay. And this one's also relevant for a lot of us on the call, is what age do symptoms typically begin? I mentioned I'm 75, but I have a younger brother who came down with this a few years ago. So it can happen at different ages. What age do you normally think it's going to happen?
Yeah, the average age that we treat is around 60 to 63 is kind of the average treatment age. But in terms of screening, you'll see some organizations like the National Cancer Network, NCCN, they'll recommend it based on your risk. So if you have high risk features like a brother or father who've died of prostate cancer, you should start at 40 getting a PSA. if you don't have any family history, then starting between 40 and 45 for PSA screening is probably appropriate. And the PSA, the level your PSA should be, is really dependent on your prostate size, which is somewhat correlated to your age. So if you're getting a PSA at 40 or 45, your PSA should be less than 1. So that's another one of those, like finasteride changes your scale, but your age also. If you're in your 60s, we often use a cutoff of 3.5 or 4 if we don't have prostate size. But something to remember too, the PSA you're expecting to see depends on your age.
So age is a factor. Are there any racial or ethnic determinants that might cause a higher propensity for cancer of this type?
Yeah, yeah. Men with African American descent, ethnicity, there seems to be some higher risk cancers in them. And so that in and of itself, if you have that family history like we talked about, or if you have a history of BRCA, which is breast cancer, but the BRCA1 or BRCA2, especially BRCA2, or of African American descent, those are risk factors which put you at a higher risk for prostate cancer, and you probably want to start at 40 or 45 for your PSA screening.
In your experience, what do you see as some of the common reasons men avoid screenings, and how can we overcome those? You mentioned the PSA, that's a simple blood draw.
Yeah. Well, if you go back 20 years, and this is when it was open surgery, radiation, there wasn't that many treatment options, basically down to an open surgery or radiation therapy. And the radiation and the surgery, those techniques were not as refined. And so I think men heard a lot of horror stories. So, side effects or complications of treatment. And then we already talked about there is low risk prostate cancer that many of those will never need treatment. And so I think because of those factors, the issue became a little clouded or confusing as to, does screening help? Could screening be harmful? But like we're saying, if you use the PSA with wisdom in context, then it's helpful.
Well, this gets back to what you mentioned at the beginning, the advances in technology, the precision that's available now
Yeah.
makes it easier for a person to say, I want to go ahead and do the screenings, I'm going to do the PSA or an MRI, because there are options that won't be so dramatic as there were 5 or 10 years ago. And I think that's important for patients to know.
Yeah, if it's a one size fits all, then that's pretty tough because you could be diagnosed with a very slow growing cancer, but if everybody gets the same treatment, that's really over treatment, or we're not, you never want the cure or the treatment to be worse than the disease that seems off. So, but yeah, now with options like focal therapy or more precise radiation or nerve sparing robotic surgery, it's changed it a lot. Or we can start trying to match what now truly we could say you want to catch the cancer early because then your treatment can be less aggressive.
Mhm. So what are the chances of developing a secondary cancer later in life? Let's say you have an early treatment and then 4 or 5 years later, you're looking at PSA levels. Is that a common occurrence? And if so, what are the options?
Yeah, if you're a good candidate, let's say you're saying if somebody has a focal therapy like HIFU or cryo or Tulsa or one of these where they don't have radiation or they don't have their gland removed. Yeah, if you're what we say the ideal candidate, meaning you have an intermediate risk and it's small, early, focal, then about 80% of those men remain free of cancer through, 3 to 5 years, meaning at 20% will go on to need additional treatment down the road. And that additional treatment could be focal therapy again, or could be robotic surgery or radiation. Um,
So I think the important takeaway from that is by using one of the newer techniques, you mentioned HIFU, you're not precluding future treatment if it redevelops, as opposed to a more radical approach at the beginning.
that's right.
Okay.
Yeah.
If a patient's found to have what's called a RAD3 spot on a recent MRI, Is it recommended to have a biopsy done locally before referring to a specialist, or how would that process work?
It's a great question. And so the PIRAD system, it's a way to try and say, if we see a nodule or a lesion or a spot on your prostate MRI, what is the risk, if we looked at other cases that look similar, of having prostate cancer? So the PIRADS 3 that you mentioned carries about a 25% risk of being actual cancer. And so that's important for men to know. Just because the MRI shows a nodule or a lesion doesn't mean it's cancer. Your question goes to what's the next step? Now, we're always interested in how is your PSA compared to your prostate size? So if your prostate's very small, and that makes your PSA actually more concerning. A small prostate should have a low PSA. So we call that PSA density. So PSA density makes a difference, as does your family history. But you do, of course, want a targeted biopsy. And it's a little up to your local center whether they do targeted biopsies. When that first came out 10 years ago, Indianapolis was, one of only a couple sites in our state that did target. And so we ended up getting a ton of referrals for targeted biopsies, and we still do a lot of referrals for targeted biopsies. Maybe, but it depends if your local center has a urologist that does targeted biopsies routinely, whether you'd stay local or go to an academic center.
Are there any symptoms people might mistakenly believe to be cancer, where really just a function of aging or some other potential problem?
Yeah, it's fascinating. The prostate cancer is a pretty silent cancer. There's not a lot of symptoms of prostate cancer. If you had the cancer for a long time, it can start to block your urinary stream. But of course, prostate enlargement can block your urinary stream. That would be a weak stream or trouble starting your urinary stream or frequent urinations or incomplete emptying. Those are signs of a large prostate. If cancer's been in your prostate for a long time, it can cause those same symptoms. But PSA catches cancer long before it's causing trouble urinating. So really the only side effects from prostate cancer, aside from trouble urinating, is once it spreads to bone, then you have bone issues, bone pain or bone fractures or weight loss. But again, that to get to that point, you've probably had the cancer for 10 years. And PSA catches it long before that point.
I'm glad you mentioned that, because my next question was going to be about metastasis and the dramatic effect that has and how to avoid that. I think everything you've talked about so far, whether it's PSA or targeted biopsy or the MRI imaging, all these early stage steps are really designed to prevent that metastasis from ever occurring, which is really the much more dramatic outcome.
Yeah, I would say in a word, the passion for my career is to replace what a urologist, Dr. Huggins at the University of, I think, Chicago, discovered, that the connection between testosterone and prostate cancer. And it is true, if you take away a man's testosterone, which is the treatment for metastasis. So, at the stage of metastasis now, the treatment is hormone therapy, but we mean castration, medical castration, or taking away your testosterone. And probably the goal of my career is that we avoid that, or we have an alternative treatment, because at the stage of metastasis, castration therapy hurts us as men, 10 different ways. It might slow the cancer down, but we're going to have weaker bones and lose muscle and gain weight and have fatigue and, potentially depression. And so you're right. The goal is to avoid that whole stage 4 metastatic prostate cancer, which is incurable. We don't have a cure for it. And those treatment options are really hard on your overall health.
So really the point of this entire discussion is to avoid that outcome at all costs.
Yeah.
Okay. Another sort of diagnostic approach, I suppose, is, can the microbiome, particularly the urinary tract, be harnessed in any way to develop a tool that accurately distinguishes aggressive from indolent prostate cancer? That's a very sophisticated question.
Yeah. And, research is so fun, and the ideas that are coming, and the trials, the studies that are being ran. I don't have any insider knowledge to the particular labs that are studying the microbiome as relates to prostate cancer. But I know there's a lot of what we call multi-omics studies, and some of them urine-based, where we participated sharing urine specimens with the startup company that was looking for prostate cancer signals for prostate cancer in the urine. That wasn't specifically the microbiome, so that's even more of a niche area. But yeah, that's wonderful if labs are working on it.
So there's some potential there down the road, but for now, the gold standard is the PSA start process.
Right, right.
Okay. One of the questions that's come in on the chat is, what about new immunotherapy treatments? There seem to be so many types. How do you know which one to try?
So, Amgen as a company just finished a trial. We were so excited. And I think for the last couple of years, we've been pushing Amgen and other companies for immunotherapies. And Amgen has an exciting one. We did some staining work for them to see if their receptor is present in earlier prostate cancer. Um, but I counsel my patients in clinic. Ultimately, our immune system is our first line of defense. And your immune system is fighting cancer, without us knowing it all the time. And if we detect cancer in your prostate, and Gina may have went through this discussion with you, we know there's cancer in your prostate, but at the same time, if you have cancer in your prostate, you have circulating tumor cells, prostate tumor cells in your blood. So your immune system's always working. The four things I like to encourage patients towards help your immune system is get good sleep. Think about when you get sick. Get good sleep, and avoid high stress, high anxiety. That secretes stress steroids that slow your immune system down. There's really good diet and nutrition recommendations. So diet, nutrition, and then the cardio, the physical activity, which helps. Now, if you're talking cancer specific, prescription specific, then those are going to be in clinical trials, because other than Provenge was an immune treatment that didn't get a lot of traction, wasn't real effective. But there's not a lot of FDA approved um, immuno treatments at this point, but I think they're coming.
Another question that came in online, do most insurance policies cover the PSA screening process?
Oh yeah, couldn't imagine there'd be any that don't cover that.
Now, as you get later into the process, and then this was in my case as well, and you start talking about the other therapies, I assume that an MRI would be covered as well. That's a fairly common routine procedure. But when you get into the things like HIFU or the TULSA or the other procedures you mentioned, do you have any awareness of what insurance covers that or not?
Yeah, we've seen pretty rapid uptake from Medicare, but the private insurers are variable. And so since we were one of the first to do focal therapy with HIFU, we've been kind of fighting that battle for a good 10 years now. And some of it comes down to published data. And so we're working on that side as well. But HIFU in Indiana, and it can be state-based too, HIFU has pretty good coverage, especially with Medicare.
Another one from online. What concerns at the age of 30 should you have with a family history of diabetes?
Yeah. Well, we're starting to learn a lot more about carbohydrates and sugar. And it seems certainly cancers like starches and like carbohydrates. And those are, at least in our Midwest diet, we get way too much. It's a huge problem. And so, if you're 30, you have a family history of diabetics, I think one of the simplest things you can do is like start thinking about your heavy starches. Your potatoes, rice, pastas, and breads, they're not very filling, and they're carbohydrates that get converted to sugar. So if you want to avoid diabetes, go, more towards what we call whole foods and more towards proteins. Um, Diabetes is just awful because it ends up killing small blood vessels and small nerves. So it's kind of a silent killer. Of course, it's connected to heart disease, it's connected to erectile dysfunction. So, if you have a family history of diabetes, just use it as a motivation. I was with my father, he's an engineer, so he's a big data guy, and he pulled out his phone and he showed me a chart on his phone from Father's Day when we were together. And I'm like, what is this? And his nutritionist or whatever put he had something plugged into his deltoid muscle that was measuring his blood glucose. And
Really?
yeah, he had a live blood glucose monitor and he had lowered his hemoglobin A1C as a measure for diabetes, and he had lowered that quite a bit. So there's a lot of tools for you now, not that you have to go all the way to live sugar monitoring that that might help with education, but you want to avoid diabetes.
So diet and general awareness of your overall health are important factors, even if you don't think about that right away when the
Um,
word prostate cancer comes up.
yeah, yeah.
Okay. One of the questions that came in today is, for me actually, is what surprised me the most about the treatment process. And you and I have talked about this at some length. I mentioned at the beginning that I was referred by a physician in Champaign who knew about your work. And I met with you, and then I met with another physician to talk about a radiation alternative. And I compared the two. And I think what surprised me the most was how direct and effective the approach you mentioned, the HIFU method, seemed to be. That is, it could be done on an outpatient basis, essentially. There were no follow-up visits, whereas the radiation would take several more visits back to Indianapolis. And the fact that it did not preclude any future treatments if this were to recur. Those are all things I had no awareness of before, but it made a big difference in my decision-making process. I don't know if you want to address any of that or how we went over that process from your point of view.
Yeah, HIFU or a heat treatment, we're only targeting part of your prostate. So um, the side effects should be minimal, and there's no like long-term side effects either. We say with robotic surgery, the side effects are upfront and get better. With radiation, there's not a lot of side effects up front, but there could be some issues down the road, 5 or 10 years from the radiation. But HIFU, there's minimal side effects. That for me as a cancer physician, the pressure on HIFU is a treatment failure. So where the HIFU doesn't get all the cancer, and so it's just and in general, when we're treating intermediate risk cancer, there shouldn't be anything lost as long as we catch it and get you to the proper treatment. So, yeah, you're saying just the convenience. There's not a lot of downtime with it's one outpatient procedure. You didn't mention there is a temporary catheter. I guess I have to be honest, but other than the urinary catheter, there's just not a lot of pain or side effects. So,
Well, that was a minor inconvenience when I thought about all the other possible
yeah,
outcomes. So I figured that
yeah,
was a good trade-off.
yeah.
And as I mentioned before, both you and your staff were just wonderful through the whole process. I shouldn't say that was a surprise, but it was a very pleasant outcome to not have to be treated like a piece of meat. I think everybody there, and at every medical institution I've been associated with over my career, that's a goal for the staff, is to treat the patients as something special. And it really made a difference in what could be an otherwise traumatic experience for a man my age. So,
Yeah, it's an interesting connection between patient and physician. When our family, obviously, we get sick too. My daughter just had a surgery. You don't have a lot of time to build trust or a relationship with your healthcare providers. And so yeah, in my case, I work with Megan as my administrative assistant, and she's phenomenal. She ends up being a patient advocate. In other words, she's texting me trying to get patients into my schedule between surgeries or alerting me with, hey, you haven't you haven't called the patient back yet. And so in the healthcare system, I think you having cancer navigators, you might call them, it's a huge deal as a constant contact, between patient and physician, facilitating everything. And mean, as a patient, you kind of want to know if I have a question that there's somebody on the other side, or if I need an answer, there's somebody there. So
Well, I'm really
hopefully,
glad you mentioned Megan's name because she was terrific as well. And that was a major part of the experience is knowing that as busy as you were, I could always get hold of her and get a response, usually within a few hours. It's really impressive. So, all right. One question toward the end here. It says, you're not only a physician, but a researcher, and you've talked about the various types of research going on, and you talked about some of the advances. What do you think are the most promising areas of research right now, both what you're doing now with some of these alternate techniques and on the horizon?
yeah, there's targets. So prostate cancer, we look for targets that would differentiate them from healthy normal cells. And there are some targets. PSMA is one. STEAP1 is another target that Amgen's targeting. And there's others. And if you have a specific target, then, in today's age with molecular science, you can potentially deliver not only imaging, but deliver treatment to them. And Indiana University, Indianapolis happens to actually be one of the epicenters in the world for radioligands. And that's where you take a molecular radioactive element, but attach it to a tracer so that you deliver radiation to the cancer cells directly. And that's a very exciting field of research that's coming, and we're trying to push. We're trying to learn more about the cancers. And I think it's funny when patients ask me, what type of prostate cancer do I have? And historically, we would say, well, there's just prostate cancer. But, that's not true. There's, each cancer is a bit unique, but there's probably some families or some classifications beyond just stage and grade for prostate cancer where we could predict their behavior better. And so now we're trying to use genomics, which is looking at RNA. We're trying to use pathomics, which is not only the, visual look at a path slide, but can we have segment smart people? You could call it AI, you could call it smart people algorithms, or uh, um, but we can look at these digital pathology, the MRI, the PET, and get more information. But hopefully, then we can better select patients for HIFU or patients who don't need treatment. And so we're trying to get better and better at patient selection as well. We're working with companies talking about tracers. One of the tracers we're working with, the company On Target, came out of Purdue University, and for the late Phil Lau, he died this year unexpectedly, but a remarkable chemist at Purdue University. He developed some of these prostate cancer specific tracers. One of them is a fluorescing agent. So during surgery, intraoperatively, we can get the cancer to glow, which of course is helpful for finding positive lymph nodes in aggressive cases. It's more on the aggressive side, or finding cancer spreading outside the prostate into tissue adjacent to the prostate. And we just finished a 20 patient fluorescent trial, and are hopeful that that's going to progress as well. So there's a lot of exciting advances coming.
With the sort of general awareness of prostate cancer and the availability of treatments, are you seeing an increase in the number of people coming for treatments at an earlier stage? Is that an improvement in this process?
It's really fascinating. And I have to go, the government has a group, the U.S. Preventative Task Force. And we would say, unfortunately, back around 2012, they recommended against PSA. So there was a government recommendation against PSA screening to the point where they would penalize primary care physicians. And they were telling physicians that there's more harm than benefit for PSA screening. And the sad part was we were just getting to MRI. We were just getting to focal image-based treatment where we can start avoiding overtreatment. So we understand it from the standpoint, if men who could get active surveillance, if men with slow growing, low risk cancer were being overtreated, that's a huge problem. Now the U.S. Preventative Task Force, either 2008 or 2012, might have been in 2008, that they said they reversed it a bit. maybe 4 years later. But I think the damage had been done in the sense there was a general sense amongst many physicians and patients that there's more harm to PSA screening. Now, we can go into the studies that made them say that, and they were remarkably um, um, contaminated studies, not well done. We could go into the details of that, meaning it's hard to randomize patients between a screening cancer and non-screening. Because in the US, if you tell a patient they're in the study and they're in the non-screening group, what do you think they do? You know, they go to their primary care and they still get screened. So um, we would argue there's the studies they were referencing to avoid PSA screening were not good quality. But even though that got reversed, I still think that slowed down momentum for prostate cancer screening. So we actually saw a wave of more aggressive cancer due to that, I think.
That's unfortunate. And here's a question for both of us, actually. For someone listening today, I'll start with you, Dr. Bahler. What's the one thing you would like them to remember from this conversation?
Yeah, I think if you're going to screen for prostate cancer, because prostate cancer is very slow moving, you're really committed to your long-term health. So, yes, we would say screen for prostate cancer, but at the same time, realize that, all the diet and nutrition side, the physical activity side, your overall health is because if you get prostate cancer, you're going to live for a long time. So you're really committed to your long-term health. If you're going to do PSA screening, realize that you need multiple PSAs, not one PSA, because that can vary by week. And that some guys just have a big prostate. So a high PSA doesn't mean you have prostate cancer. And you want to be at a center now that we talked about earlier, where they have image guided, targeted biopsies, MRI. I would recommend before you get a biopsy, you should always have an MRI. If insurance will cover that, it's a better biopsy.
Well, from my perspective, I think the one thing I would like people to remember or to take away is take responsibility for your own health. You can trust the physicians, great deal of trust in Dr. Bahler and Megan and the other folks at IU Health, with my local physician, Dr. Regan. But ultimately, it was my awareness of my consistent PSA levels over years, my learning about the effect of finasteride and PSA, which led me to realize that the numbers were wrong or misleading. That started me on the path. So take responsibility for your own health, your diet, your exercise, the things Dr. Bahler talked about. But don't be afraid to get the blood test done. Talk about it with your primary care doctor, and then lay out a plan of action. Don't wait till it's too late, because the options are much more limited. In my case, and probably in thousands of others, by being assertive at the beginning and knowing what you wanted to accomplish by learning about your PSA levels, your other blood chemistry, we were able to take a path that gave me a lot more options. So take responsibility for your own health and then trust the experts down the road when the time comes.
I love it. Yep.
Okay. I don't see any more questions coming in online, so let's begin to wrap this up. I want to thank you all for joining us for this month's Simon Says, and Dr. Bahler in particular for expertise in your time. We want to invite all of you who are watching to an upcoming event on Saturday, September 12th, a few months from now. The IU Simon Comprehensive Cancer Center will host its second annual Outpacing Prostate Cancer event from 10 a.m. to 1 p.m. in downtown Indianapolis at the Scottish Rite Cathedral. This event will include a lovely brunch, a presentation from IU experts in prostate research and treatment, and a question and answer period with the audience. This event is totally free to our participants from our sponsors. Anyone's welcome to attend, so mark your calendars and bring your significant other or family members. That's important. At 12:15, we'll have an optional celebratory walk on the downtown canal to celebrate the prostate cancer community and hope that we can outpace this cancer together. Everyone who registered for today's Simon Says event will receive an event RSVP detail and a follow-up email. We hope to see you with us in future cancer events. We hope you find a recording of today's session and information about upcoming events at cancer.iu.edu/Simon Says. Once again, thanks, Dr. Bahler, and to all of you, have a great day.
Gene, it was a pleasure. I really appreciate your work here.
Oh, not a problem at all. I enjoyed it.